we want to talk about joint pain in neurologic patients. When we talk about orthopedic problems in this topic, we talk about musculoskeletal disorders. We will discuss in this session about heterotopic ossification. There's no slide.
We see the introduction slide.
Yes, it's correct. We talk about heterotopic ossification. We talk about osteoporosis, ROM limitation, joint malalignment, and joint pain. We talk about these problems in 5 aspects. We talk about documentation and measurements. We talk about their nature. We talk about the determinants, implications, and in the last topic, we talk about treatments. Here, we talk about heterotopic ossification. What is the heterotopic ossification? When we have ossification in the soft tissue in an abnormal location, we call it heterotopic ossification. When we want to talk about its documentation and how can we measure it, we have some signs. We have soft tissue swelling, warmth, erythema, fever, and when the time goes, the swelling becomes more localized and the tissue becomes firmer to the palpation. We can use radiographs like X-ray to see the heterotopic ossification. We can use the serum level of alkaline phosphatase as another indicator to the heterotopic ossification. In this picture, you see the heterotopic ossification on greater tubercle of the humerus. You can see some shadows on the greater tubercle of the humerus. This is heterotopic ossification. Also, we can see some degenerative changes in the HC joint, acromioclavicular joint. This is the X-ray, and we can see the heterotopic ossification in X-ray pictures. Okay, let's talk about its nature. Who is at risk? The studies showed that we have 30% in SCI patients. It is much more common in cervical and thoracic SCI than lumbar, and 22.5% in TBI patients. It is important to know that HO seldom involved the muscle mass, but it is occurred in connective tissue planes between muscles. And in the hip joint, it is more common than in knee or shoulder joint. When we want to talk about its determinants, the exact determinant of HO is a mystery. But in some aspects, we see that immobilization can lead to HO and not have weight-bearing exercises. It is much more common to have HO. What problems can it make for us? The HO itself is not problematic, but it can cause some problems in ROM. It can lead to pain, ankylosing, or nerve and vascular compression. So it is important to treat it as soon as possible. How can we treat this problem? At first, we should use ROM exercises. ROM exercises and weight-bearing exercises can prevent from this problem. If it is not effective, we can go to the surgery session, or we can use pharmacological treatments. For example, disodium ethidronate prevents bone mineralization. The second problem that we can have in neurologic patients is osteoporosis. What is osteoporosis? When we have our bone mass diminished, it can lead to the increased chance of fracture. It is our first concern that if any patients have osteoporosis, it can increase the chance of fracture. How can we measure the osteoporosis? We have a method. It is called photon absorption. What is photon absorption? The absorption of radioactive substance by bone tissue is proportional to the bone mineral content. We use Z-score and T-score to determine and to measure the osteoporosis or osteopenia. Okay. What is the determinant for osteoporosis? When we have decreased muscular contraction and weight bearing, it can lead to decreased stress on bone. And finally, it can lead to osteoporosis. Who is at risk? CVA patients in the hemiparetic side and the SCI patients have osteoporosis more than others. What problems can it make? As I said, it is the greatest concern to physiotherapists is fracture risk. Osteoporosis may lead to increased fracture risk. Okay, we should prevent to have osteoporosis. We should prevent the bone to become the osteoporotic. What can we do? Exercises like weight-bearing exercises. As the studies said, it cannot stop it, but it can make it slower. We can use pharmacological treatment, but in some studies, it is said that cyclical ethidronate in some studies showed no significant reduction in bone mineral density. But we use it. As the study said, it has no effect on mineral density, on bone mineral density, but we use it again. The third problem is ROM limitation. It is often of a concern to physiotherapists too. How can we measure ROM limitation? The simple method is goniometry. The goniometry is a method to assess ROM. When ROM is measured, the structures that limit the ROM are not identified. We cannot say if the muscle, if the ligaments, if the joint pain, which one of them limits the ROM. Let's talk about the nature of ROM limitation and determinants. When we have a neurologic pathology, the muscle weakness can cause ROM limitation. In CVI patients, in TBI patients, and in CP patients, it is more common than others. In CVI patients, the shoulder elevation, the shoulder external rotation, and ankle dorsiflexion is limited much more. In TBI patients, they may have equinus deformity. What is equinus deformity? The plantar flexion of the ankle is the equinox deformity. And they may have knee flexion contractures. In CP patients, they may have limitation in ankle dorsiflexion, in hip and knee extension too. When we want to discuss about the determinants in ROM limitation, we prefer to discuss at two levels. The first, ROM limitation by other impairments. The second, ROM limitation at tissue level. When we want to talk about ROM limitation by other impairments, we should consider muscle weakness as a determinant to the ROM limitation. But there is lack of evidence in this field. When we talk about ROM limitation at tissue level, we can say that it is originated from muscle tendon or from the joint. Although reduced number of sarcomeres in series can lead to reduced muscle length or ligament changes, the CNS and the PNS and other soft tissue has adaptation to this change in ligaments or this muscle length. And finally, it can lead to ROM limitation. It can affect in our normal ADO, in our normal functional activities. So, also, it has some effects too. It can also alter the mechanics. For example, limited knee flexion needed excessive hip flexion gait. It can cause some disturbance in gait, and it can lead to gait problems. Also, the ROM limitation may increase pain, like in shoulder, and the pain also can increase limitation of ROM. So they have interaction with each other. What treatments can be used? We have three phases. The first phase is to reduce the existing limitation. The second phase is to prevent a future limitation. And the third phase is to a slow progression of limitation. We have surgical and non-surgical, or both of them with each other. In surgical treatment of ROM, we direct at the tissue thought to be limiting the ROM. For example, if the capsule is in incorrect position, or if the capsule restricts the ROM, we can use capsulotomy. If the muscle tendon has inadequate length, we can use complete muscle release by tenotomy. For example, hip abductor muscle in CP, subscapularis muscle in CVA patients, they use by tenotomy. Another method in surgery is aponeurosis lengthening. For example, Achilles tendon in CP, but studies showed that it is not permanent if you lengthen the Achilles tendon. We have non-surgical treatments too, like exercises, cast, S-split, and electrical stimulation. What exercises? The passive ROM, the stretching, can increase the ROM. But the prolonged stretching over 30 minutes by a tube table or a splint or pulley, traction or CPM, it is much more effective than the short one. In animals, it is showed that Heating plus stretching has good effects on ROM increasing. A splint and cast are used to slow or prevent or increase the ROM. And the serial cast is used too. In some studies, femoral nerve stimulation is used in patients with knee flexor contractures or wrist extensors in stroke patients. The next problem is joint malalignment. What is the joint malalignment? The misorientation of bones making up a joint. This is joint malalignment. Here we discuss about subluxation and dislocation of the shoulder and hip joint because it is important and the joint is important in biomechanics and it is more common than other joints. First, we talk about hip malalignment. It is the femoral head on the acetabulum. How can we measure it? We can observe and palpate to know about subluxation and dislocation of the hip joint. Also, we can see it in radiographs to measure the center edge angle. It is also important to know 59% in CP patients, they have joint malalignment. But why? Why they have joint malalignment? The muscle weakness is an important factor that can cause joint malalignment in hip malalignment. For example, gluteus maximus and hip abductors muscles are so important to make a balanced hip. And if the patient has not adequate walking or weight bearing, it can cause hip malalignment too. There is a note. In leg length discrepancy, we can see hip malalignment in the longer limb. We can see dislocation, subluxation in the longer limb. What problems and what treatments do we have here? It can cause hip pain and back pain if you have a hip dislocation or hip subluxation. Also, this is the note. Limited walking leads to hip rooted. If you have enough walking exercises, you may have less chance to joint malalignment. So walking is so important. We have some surgical treatment. There is no PT programs in joint subluxation or joint dislocation. The surgical treatment is used if you want to release of hip abductor and the posterior transverse of psoas, and after surgery a splint may be used. But the hip flexion may be weakened and the abductor contractures may be seen. It has some side effects. The hip flexion may be weakened and the abductors contracture may be seen. Let's talk about shoulder malalignment. It is so common to have inferior subluxation in stroke patients. We can measure it, as I said, by palpation in some scales, non, minimal, or substantial subluxation, or by the number of finger breaths separating the acromial process and the humeral head. In radiographs, if we see a V-shaped space between the humeral head and glenoid cavity, we can assess and we can conclude that it has the joint malalignment, the shoulder malalignment. Let's see. This is the V sign between the glenoid cavity and the head of the humerus. If you see this V shape, you can conclude that this is a shoulder malalignment. Okay? Weakness of shoulder elevator muscles, like supraspinatus, can be a determinant too. So, weakness of shoulder elevator muscles is so important. It can have some problems in biomechanics, and also it can cause some pain in shoulder. So, CKC exercises. Why it is so important to have CKC exercises? When you have CKC exercises, you have co-contraction of muscles. When you have co-contraction of muscles in shoulder, you can increase your stability of your shoulder. So, if you increase your stability of your shoulder, the chance of shoulder malalignment should be decreased. If the shoulder malalignment, shoulder subluxation and dislocation occurs, you can use arm sling or taping. And it is said that FES, functional electrical stimulation, on the deltoid and supraspinatus muscle can reduce the chance of joint malalignment. As I said, weakness of shoulder elevator muscles, like supraspinatus, can be a determinant. So, if you strengthen the deltoid and the supraspinatus muscle, it can be helpful. The last problem is joint pain. It is a general topic. It is common in stroke patients, 55%, ASCI patients, 64%. And the shoulder joint is more common than others. So we talk about shoulder joint pain. We have a Ricci articular index. We describe 0 point with no pain, 1 with complaint of pain, 2 with complaint of pain and wins, 3 with complaint of pain and wins and withdrawal. We score it in this index. And we have Fugger-Meyer is 2. It is a questionnaire to assess the shoulder pain. You can have more research or more search to know about the Fugger-Meyer questionnaire. Okay. The shoulder pain in a stroke and SCI patients have similar characteristics. But here we discuss it in 2 groups of patients. In a stroke patients, we have 45% that have pain in rest, and 100% of patients have pain in movements. So, if you assess the pain, the shoulder pain, in movement or in rest, in the movement they have more pain than rest. Although the CVA patients, 2 months after their CVA, their pain starts. And then when the time goes, when the time passes, the severity of pain tends to increase. So, when you assess their pain in the movement they have much more pain. After 2 months after CVA, the pain starts. And the severity of pain tends to increase when the time passes. In SCI patients, in the paraplegia patients, we have 36% that they have pain. As 46 of patients with quadriplegia have shoulder pain. So, shoulder pain in the quadriplegia is much more common than paraplegia. Okay? As I said, when you have restriction in your ROM, you may have shoulder pain. And when you have shoulder pain, you may have ROM limitation. Contracture, capsulitis, found to be the most common etiology of shoulder pain. Weakness. This statement is so important. Weakness is a necessary but not sufficient cause of shoulder pain. If you have weakness, you have the risk to have the shoulder pain, but it is not sufficient. And the shoulder subluxation is an important factor too. What problems we have by joint pain? It can affect in our functional activities, severe loss of sleep. When you have joint pain, exactly shoulder pain, you can be annoyed by loss of sleep. And you may have longer hospital stay too. What treatments can be used? We have some pharmacological treatments, some tablets, some capsules to reduce the pain. But physiotherapy can have a major role here. We can use ultrasound, we can use positioning, cryotherapy, manual therapy, exercise therapy, and so on. The physiotherapy can have a major role in treatment of the joint pain, exactly, especially the shoulder pain. And if they are not effective, they may go to the surgery step and so on. Thank you for your attention. Uh, Thank you for your collaboration. If you have any question, I am here to answer you.
Thank you, Mr. Esmaeeli, for your presentation. If anyone has a question, please raise their hand so they can ask their questions. Comments, questions, anything that you want to share with the rest of the group?
Thank you, Doctor.
Doctor, what we ask, is HO common in orthopedic disorders?
Yes, any orthopedic disorders that can immobilization. The immobilization is a major risk factor in HO. So we can have it too in orthopedic disorders. Yes.
What is your opinion about the stretching?
Stretching in HO, as I read before, in HO we can have active ROM exercises, but stretching is not an efficient method in HO. And as I read before, the passive ROM is forbidden in HO in heterotopic classification, as I remember. Thank you, Doctor. I am so grateful to have you in this conference. Thank you, Dr. Marmir.
Thank you very much. If there is no other questions, I think we should call it a session. Thank you everyone for being here. Thank you very much.